the challenges and also the ease of getting people to engage in hepatitis C treatment, even though they may still be actively injecting drugs. So it's a hodgepodge of slides. I hope that that if anything, people can at least learn one new thing doing this today. So you can, next slide. Harm reduction and people who use drugs. We're talking about a spectrum of drug use, right? That goes from the highest risk to the lowest risk. And we know the highest risk is injecting drugs. And then smoking, eating, abstinence, snorting, vaping, skin absorption. So it goes from highest to lowest. And a lot of times what I try and ask people before we begin hepatitis C treatment is, do you think that you could, that you could stop injecting and snort, your fentanyl or heroin during treatment, or, so that we go from highest risk to one of the lower risks. And sometimes people will do that because when you refer people, I'm thinking of one person in particular who was middle-aged in his mid-50s, had hep C for a long time, incarcerated. They never treated his hep C while he was incarcerated. And he was going to see a hepatologist here in Philadelphia. And I said to him, when you walk in there, probably somebody's going to ask you, when is the last time that you shot up? And maybe you could say to them, I'm not using, I'm not injecting drugs right now. I'm just snorting. And that could be a lower risk that might at least get them in the door to have a hepatologist see them. This was somebody who was cirrhotic. But because she said, you need to leave and you need to come back once you decide that you're not going to inject drugs anymore. So I'll talk a little bit more about that later on. Next slide. About what Prevention Point does. Let me see if I can. So we have a syringe exchange program here along with a whole bunch of other programs, but this is how Prevention Point started out. We were a syringe exchange program when there was, what we will be, we're celebrating our 30th year providing services in this area in North Philadelphia. So the syringe exchange program, we have about 23,000 unique participants. We distributed 6.4 million syringes last year, 650 participants per day. And we have our syringe program that runs twice a week on Tuesdays and Fridays. People can also stop in and, our high-risk patients who identify as having Hep C or Hep B or HIV can also get what we call a 10-pack for the day until the next open syringe program. The people who are also high risk get more syringes than somebody who's just walking up, and there's nobody identifies. There's no name. People get a number, walk in. They bring their old syringes in so that we can dispose of them. We have overdose prevention services. So about 70 to 140 overdose kits dispensed per mobile site. So that is usually per week. When we see that there's like bad dope in the neighborhood, we will, especially if there's been an overdose, whether it's fatal or non-fatal, we will go out to where that overdose happened and just flood the area with Narcan. We also have a level of care assessment services. So this is for people who may want to pursue detox or drug and alcohol rehab. We have drop-in case management. So anybody who presents to our, what we call our drop-in, where people can just come and sit and have a cup of coffee, they present to drop-in. We have case management services for things like people need IDs, they need some legal services, they need, if they want to make their mailing address here at Prevention Point. So we have about 3,800 people who use Prevention Point as their address. This is really important in order to be able to get any services like health insurance, or because most of the people we take care of are unsheltered. Beacon House Shelter, which is a few blocks away from our main building, houses about 60 people. Spiritual counseling, we have what's called the listening program for staff and also for our participants. And then we also have police assisted diversion, which is rather than somebody being locked up for paraphernalia or for disorderly conduct or even just being homeless on the streets, the police in the area know to take a client to our PAD office. And then we usually have a negotiator. We have some bargaining that we do as far as helping the person either get into drug and alcohol resources or be an advocate for them so that they are not locked up for a long time. Next slide. So go back one, thanks. So we also have a medication for opioid use disorder, which is called our STEP program. We have about 186 people currently enrolled in the STEP program. We have PrEP. We're really excited about the new injectable PrEP, and we're switching everybody from oral to injectable if they would like that. And that will eventually come out to just 6 shots a year to prevent HIV, which is pretty fantastic. Our PrEP team has navigated about 584 people in the last year. We have an HIV Hep C point of care testing. They test about 130 people per month. So they're available on our days that we do syringe exchange. And they're also available if people walk in and want to get tested. Our HIV care, we have about 65 active participants right now. We have close to 100 that are in and out of care in this area, but about 65 that we're actively taking care of. Our viral hepatitis care, we have about 15 people right now co-infected with hepatitis B. I just went in and checked labs this morning. We have another one. So this is all related to sharing works and syringes. We have a reproductive health care program. We have about 19 people currently enrolled on DEPO. We offer vaccinations for our participants. So if they come in and they're being screened for the PrEP program or for opioid use disorder, we usually will draw a panel of labs that include hepatitis A and hepatitis B, and then we will vaccinate them if they need it. We have wound care 3 days a week. And during the pandemic, we usually had about maybe 500 people who sought out services. And since 2020, 2021, even more, about 1,000 visits annually. This is a nurse-run program. We have nurses who dedicate their time 1 day a week and they rotate. And then the 3rd day of the week on Fridays, we have a surgeon who comes in and helps with debridement of wounds. We're seeing a lot of soft tissue infections, osteo, a lot of necrotic wounds because of the xylazine injections, the tranq that people are injecting. We also have a mobile bus van for medication-assisted opioid use disorder, about 180 people. And that's just a short term. People rotate through services. They get about a month to 6 weeks, 8 weeks on the van, and then they are helped to go to more permanent services. And we have 2 wonderful phlebotomists. Phlebotomy is key in any of the things that we're doing right now until we can come up with, a drop of blood. But for right now, a lot of our people are really difficult sticks. But we have 2 great phlebotomists who have never missed, which is really great. Next slide. So Philadelphia has the highest overdose death rate of the top 10 largest US cities. We see that red line. Next slide. Unintentional drug overdose fatalities in Philadelphia during 2020. There were about 1,200 unintentional drug overdose deaths. Fentanyl is increasingly in every drug supply, whether it's weed, it's pressed pills, it's in everything, including pharmaceutical opioids, meth, PCP. So deaths among non-Hispanic Black individuals increased during 2020, while deaths among non-Hispanic white individuals declined. So this is a population that we really need to zero in on and say, why is that rate higher than others? And of course, it has to do with health disparities and making an intention to go out there and find folks who need our help. Next slide. So this is just a little bit to talk about emergency room visits for skin and soft tissue infections with co-occurring drug-related diagnoses. So we see this sort of from 2019 to 2021, the increase in the rate of emergency room visits in this area. So this is where our nurses come in with our wound care, because they approach wound care as a harm reduction encounter. And a lot of times we'll get our referrals for Hep C, HIV, case management, all those from the nurses themselves. They're an incredible group of nurses that are really dedicated to doing harm reduction. And it's interesting because sometimes we'll get residents that come through, and you look at somebody's leg or arm, and especially a tranq wound, and you say, you need to go to the hospital right now. And it's like, they're not going to go to the hospital right now, right? They've been taking care of these wounds themselves, or they come in and they see the nurses. A lot of times they're bored when they're admitted to the hospital, even though we might be managing their opioid use disorder with incredible, 400, 600, 800 milligrams of OxyContin. They're not in pain, but they're restless because they're away from their community. A lot of times they can stay in for maybe 2 or 3 days, and then they self-discharge. So maybe we've gotten a couple of days where we were able to debris the wound and then maybe talk later about a skin graft. Next slide. So beyond the wound care clinic, 28% of participants report a hospital visit for the wound they present with in the clinic. Wound care refers many for hospital care, for imaging, to rule out osteo, sepsis, DVT. We have people who are on call the 3 days for wound care that they can send a picture, either telehealth, or when I'm here, I'll go around and assess the wound, and then we can intervene with antibiotics, usually PO antibiotics. We're working on getting sort of an outpatient IV antibiotic suite set up here for Dalvance, which would be great, because then our folks wouldn't need to stay in a rehab for 12 weeks. They could get, 2 shots of Dalvance and be okay. So the number that we see in need and who we refer to the hospital, who actually go, you'll see that that's just the tip of the iceberg. And then we have this huge group of people who are very reluctant because of the stigma associated with IV drug use, because of the stigma of, they're very embarrassed by their wounds. I mean, these wounds are very personal, right? It's part of this person, and they might give off an odor. They might, they can't fit into shoes if it's a lower extremity. So there's a lot of shame and a lot of stigma attached, self-stigma, and then what they receive when they do present in the emergency room or the hospital. Next slide. So the opioid crisis is, again, this is just talking about our endocarditis, bacterial infections associated with intravenous drug use. Xylazine leads to wounds that are very difficult to treat. So again, this is a huge piece of what we do here as far as harm reduction, is our wound care clinic. And it's really a wonderful bridge for people, because they come in, they're taken care of, they're not forced to go to the hospital, they're not forced to take antibiotics. what we try and do is just surround them with the knowledge of how to take care of these wounds, give them wound care supplies, ask them to come back a couple of times a week, just so that we can keep an eye on it and make sure that it's not getting worse. Next slide. These are a few of our favorite things that we use in the wound care, Meta Honey, Xeroform, the little lanyard down here with the blue the blue tie around it. We usually will put people's medications in that, either a couple of days worth of Bactrim or Doxy. That's what we have in stock here, but sometimes we also need to do more than one antibiotic for some wounds. And we just put it in this because a lot of times everything is stolen. As soon as somebody falls asleep, as soon as somebody injects and they get hit really hard with the injection and they sit down and they sleep for a while, everything will be stolen by the time they wake up. Their backpack, their shoes, their coat. So a lot of times it's harder for people to go into clothing to get these medicines. So a lot of times people will keep their Suboxone in there, their Bactrim, their Hep C meds. We have people who come in daily for their medications for Hep B, HIV, Hep C, because there's no place to store their medications on the street that's safe. Next slide. So again, this is just looking at people, the people who come in and go to wound care clinic. They have been taking care of their wounds for a very long time. And a lot of times they're even more skilled at being able to do a debridement, to lance a wound. So a lot of times what we do is just say, come in, let us help you, figure this out. So 32% report purchasing antibiotics from friends or corner stores. So we have people who sell antibiotics on the streets here. 54% report IND performed by a non-medical professional. So that could be somebody who's really good at lancing wounds in the neighborhood. 38% reported delaying care for infections by greater than 2 weeks. So next slide. Some of the key principles of harm reduction is to understand that drug use is complex, multifaceted. It encompasses behaviors from severe abuse to total abstinence. Meet people where they are in the course of their drug use. Harm reduction affirms and empowers drug users and communities to be their own primary agents of change. Designs and promotes public health interventions that minimize the harmful effects of drug use. So basically what this is saying is, a lot of times what our folks do here is, motivational interviewing and say, what would it take for you to come in and pick up your medicines every day? What would it take for you to change your dressings on your wound more than once a week? And then when people are ready to take the next step, you're there to offer that to them. But it's not something that we say, you need to do this in order to receive care here. Next slide. Sizes, for overdose prevention, to test before you fly, go low and go slow, use a familiar, comfortable place, use with people that you know, never use alone. Try not to mix your drugs. Some chronic conditions reduce the ability to metabolize drugs, such as hepatitis C, such as someone who has a really low CD4 count with HIV/AIDS. Tolerance is really low after someone's been institutionalized, incarcerated, comes out of a detox treatment. Even if they've been abstinent, even after a few days, there's a high risk of overdosing, especially when they come back to this neighborhood. We're really, next slide. Talk about addiction. Why can't they just stop using? I mean, people know how irrational drug use is. They'll say, I know this is insane. But my brain has been hijacked and I'm not sure how to get out of this. And sometimes when you come to Kensington, it's a hard place to get out of, because drug use is escalated. It's abundant down here. There are samples that are given out frequently during the week and everybody runs to get free samples. Anyway, next slide. So we know that drug addiction is a chronic relapsing brain disease, right? So it's compulsive drug seeking. It can also be accompanied by self-destructive behaviors, and continued despite the harmful consequences. And the brain is actually, it can be rewired where people are, it's really hard not to want to inject, even if you're on Sublocade. People will still top off with other things that are not opioids because they have the need to inject. So what we try and do is compare this to disease persistence rates between drug addiction and other chronic illnesses. So we know that if you stop taking your insulin for type 2 diabetes, that your diabetes does not go away. It remains, it's still there. If you become abstinent and you stop using opioids, the addiction is still there. It's the same with hypertension and asthma. You still have this underlying disease persistence, even if you're not using anything. Next slide. Addiction coexists with numerous compounding realities such as poverty, homelessness, marginalization. People have severe mental health comorbidities, incarceration, and then just the medical stigma that's attached with intravenous drug use. Next slide. Two epidemics that are intertwined. So hepatitis C infection is just a serious health consequence of injection drug use. And we know that when people first start injecting, 1 of 3 people who inject drugs acquires hepatitis C infection in the first year. And then we have about 45 to 85% of individuals chronically infected who are unaware of their status. And this is why point of care testing is really important. People will come in and get tested and say, I had no idea. Or we have serial testing where we test, especially our high risk folks, every 3 to 6 months, and maybe they were negative for Hep C antibody 3 months ago. Or 6 months ago, and then all of a sudden they come up positive, then that's an opportunity to send them to the lab and to get all the labs that we would need in order to think about treating for hepatitis C. Next slide. Some of the harm reduction practical strategies for reducing negative consequences. So we know that opioid substitution treatment works. We know that needle and syringe programs work. Combined mental health services for opioid substitution and syringe programs. If you co-locate those services, people might be more willing to accept them. Also to recognize that a lot of non-viral infections and medical consequences of injection drug use, such as what we talked about, soft tissue and endocarditis infections. And to look at harm reduction as hepatitis C prevention, right? Infection and reinfection will happen, but harm reduction, if we treat X amount of people in our community and they no longer have hepatitis C, then if there is any incidence of sharing either syringes or works, we've decreased the pool of people who have hepatitis C in our community. We want to inform people, educate, continue counseling. Currently, the only safe injection facilities are in New York City right now. We have been trying to get one in Philadelphia for years and years, but have not been successful. Next slide. So we know that opioid substitution has multiple benefits, right? It's safe and effective in suppressing illicit opioid use. It improves mental and physical well-being. If people are retained in an opioid substitution treatment, we know that there are decreased reductions in overdose mortality and also in all-cause mortality. And part of this is just because you're keeping people connected You are keeping an eye on them. Next slide. With greatest access to syringe programs have the lowest rates of Hep C infection among people who inject drugs. So we know that if we're providing sterile syringes and other equipment, people will be less likely to share injection equipment and use sterile syringes. They'll be less likely to maybe engage in a higher risk behavior. We try and educate people about hepatitis C risks and prevention, and to link them to screening, diagnosis, and treatment. Next slide. Hepatitis C treatment. I know this is what I'm supposed to be talking about, right? But in a harm reduction setting, there's so many things that come before this. Next slide. So if we look at who should be treated, the American Association for the Study of Liver Diseases, the Infectious Disease Society of America, treatment is recommended for all patients with chronic hepatitis C infection, except those with short life expectancies that cannot be remediated by treating Hep C by transplant or any other direct therapy. So direct acting agents for people who inject drugs with hepatitis C infection, they're not different just because people are injecting drugs, right? Next slide. So, in considerations in people who inject drugs. So after people are cured, they will continue to have positive hepatitis C antibodies, and it's not protective antibody. It doesn't protect them against reinfection. Expect reinfections. It means you're treating enough people and you're treating the right people. Okay, expect people to be reinfected. So modeling studies indicate that MAT and treatment as prevention, like we do in HIV, are important for slowing the rates of new infections and reinfections. With the hepatitis C cure, you have decreased prevalence. With harm reduction measures, you have decreased incidence. So harm reduction strategies such as direct acting treatment of injection partners, like bring a friend into treatment strategy, can also be useful for reducing reinfection. Also, just going up and down the street and, but we mostly know the people who are living, in tents on the street and just sort of saying, do you want to get tested today? Do you know whether or not you have hepatitis C? Just doing that intervention can sometimes be helpful. So access to treatment for hepatitis C reinfection, we want to do that without stigma or discrimination. It's crucial because reinfection is not unique to people who inject drugs. Okay. Next slide. So this is the last slide, and basically it's just, understand the barriers to people who inject drugs engaging and being retained in care, in hepatitis C care. Apply harm reduction principles across the hepatitis C care continuum. Support collaboration with harm reduction programs. Understand the evidence-based feasibility and efficacy of Hep C treatment in people who inject drugs. So these are, what I try and do is when I'm talking to other providers and they're very reluctant to treat somebody who's actively injecting, I try and show them the studies out of Australia, Jason Greebley and also Alana Rosenthal in DC. So these are two studies that are done with people who are actively injecting and very high cure rates of hepatitis C. To treat hepatitis C infected people who inject drugs in accordance with the AASLD guidelines, okay? Stay connected after a cure for better long-term outcomes. So sometimes people will go through treatment, get cured of hepatitis C, and then still be retained here in our medication for opioid use disorder program and our STEP program. So I am open for any questions. I did not elaborate on hepatitis C treatment because I think what I want to say is everybody should be treated, right? Whether you are someone who's injecting drugs or not. Care is out there, and it takes, in this community, it takes a whole group of people to make it happen for somebody to get their medicines every day, to be able to come in and pick up medicines daily, to be able to obtain their blood. through a successful venous puncture and not have to send them to 5 different labs, because we lost so many people before we had our 2 phlebotomists who are so great right now. So basically, everybody should be treated. If I can treat people in this community and they can cure themselves of hepatitis C, anybody can do this. Okay, anybody, any provider can do this. Yeah, we had a person who we treated who slept in front of the building every night and was really very, very deep in his addiction. And we would just, walk by him in the morning and just sort of shake him and say, when you're ready for your coffee and to take your medicines, come on in. And that's what he would do every morning. And this is a person who I never thought would cure from hepatitis C, cured. Okay. So I think the 2 big things that people have problems with or questions about with people who inject drugs are adherence and reinfection. And those should not stop anyone from not treating somebody with hepatitis C. Okay, because anybody can have problems with adherence. Okay. Anyway, okay, I'm open for questions. Thank you for listening. I hope it was informative.
Hi, Jody. This is Jill from the CLA. I'm curious to know. I know in Philadelphia, with a dense population in the city, it's easy to recognize your patients or people who are in need of treatment. What are your suggestions for finding people who are in need for treatment in maybe a more rural area or not as dense of a populated area?
I know that there are a lot of, these telehealth things springing up, like Ophelia, right, that are doing a lot of MOUD in rural areas. And I think what they're also starting to do is ask if people would want to be tested for hepatitis C and treated. I personally think we should be using ECHO to treat those folks, and we should be connecting with primary care providers.
Okay, great. Thanks so much.
There's a note. It says, I was told by another provider here that after medication and remission, it's more difficult to get rid of it a second time if they get reinfected. Is this true, Jody?
No, not true.
I guess one of my questions, this is Susanna, is what about reinfection? What are the rates? What can you tell us about that? Are there any rules that preclude people from being retreated if they're reinfected?
I can tell you that trying to think of people who were reinfected. So I think, you have to get more creative. If somebody's on their 4th treatment, you want to try and get them through the easiest thing, right? Which would be, either 8 weeks of treatment with 3 pills or 12 weeks of treatment with 1 pill once a day, rather than going to, now you're on your 4th round. And now maybe we have to add ribavirin. You don't want to do that. So I would say that it's challenging. This particular hepatologist that I sent a patient to, these were her 2 main concerns, were reinfection and adherence. And when the patient came back to the office and said to me, why would you send me there? She told me that I had to stop injecting drugs and come back in 6 months when I stopped injecting drugs. And I thought, I know this person. And he said, well, why would you send me to somebody like that? And I thought, I know this person. This person just needs a little push and to be educated. So I said to her, do you know what when he came back, we both called, he sat in the office here and me, and we both called her together because I had her cell phone number. she said to me, well, why would I want to do this? Why would I want to treat somebody who's still injecting? And then they're just going to get reinfected. And I said, okay, well, here's the rates for people who inject drugs is somewhere around, I believe, 10 to 15%, maybe lower than that. The reinfection rate for an HIV positive MSM is greater than 20%. So what if that person walked into your office and they were, an HIV positive men who have sex with men, and you said to them, excuse me, but until you stop having high risk sex or until you stop having sex, I'm not going to treat you. Can you imagine the lawsuit?
I
So she said to
agree.
me, okay, that makes sense. So, well, this is similar. You have the answer and the power to cure someone. Why would you withhold it
I'm with you
when this person is going to
100%.
get their life together? You treat them now and you cure hepatitis C when it's, an F score of like F1 or F2, and then, you have hepatitis C treatment in one hand and you have addiction in the other, and you never know when divine intervention is going to happen to help somebody get out of this world, get out of Kensington, stop injecting drugs. It could be tomorrow. It could be a year from now. It could be 5 years from now. It could be never. But that doesn't mean that you withhold treatment from someone, because you wouldn't do this in any other situation. You would not do this to somebody who has a cardiac issue. You wouldn't say, stop smoking and then we'll put your stents in. They can offer that, right? They can say, we would like you to stop smoking, but somebody presents in the ED with an occlusion in a coronary artery, they're not going to demand that they stop smoking at that moment. So I don't know. I feel pretty strongly about it. I think people just need to be educated, and open their minds to the fact that just because people are sort of lost out here on the streets doesn't mean that they don't deserve good care and that they don't deserve treatment for hepatitis C.
I agree with you. I had a tour, Prevention Point Pittsburgh, and Philadelphia was pretty impressive. Tell us a success story. We're always looking for, the hope, Jody. And I know that you've done lots of work with lots of amazing people who, are on the road to recovery and to a cure.
I can tell you that, I probably always shoot for, not always, but because this is a transient population, a lot of times people will panhandle here in the neighborhood and then they go to Center City and panhandle and maybe they're there for a couple of months. I try and go for the shortest duration of treatment. And we also incentivize our visits. So if you get your blood taken, we have $10 that we give you. You complete your first month of treatment, you get a $25 gift card. We apply for grants in order to be able to do this. So I think, and some people will say, well, you're just giving them money to go buy dope on the street. And it's like, yeah, maybe, but I'm not following them and knowing whether or not they do that. They could also be going to Walgreens and getting some food, or, to McDonald's. We try and get gift cards that are food related. But again, it's a very strange world. Like, people will sell their gift cards sometimes, and go without food because their addiction is their number one priority. So I think the success story comes in treating people with respect. It's always a two-way street. Now that, we're wearing masks and, we're still wearing masks here in Philly, but like to be able to touch people and to say, you're going to be okay. Because it always ends up being something about a family that they haven't seen in years, or a child that they want to reunite with, or, all of those things, all of those human factors that make us who we are. So I think just the success comes in, I think, in respect and offering treatment to people, and saying you are worth this. There may be nothing else in your life that you can be successful at. But you can take this medicine every day, and people feel so good about completing treatment. It's like a pat on the back. It's like, wow, you did that. And that's really hard in this environment. So that's the only thing I can say. There are plenty of failures, but we just keep plugging along.
Well, it's good work that you do in the communities, and we appreciate you being here to teach us and to educate us on harm reduction and compassionately treating people who inject drugs, who use drugs. Does anybody have any other questions? Jill, I don't know if you have anything else.
No other questions, but Jody, thank you so much. I think this talk was really productive, and I really appreciate your perspective on it. And I do think that, there has to be an emphasis on the respect going both ways, and us providing respect to patients, no matter what their background or what their habits are. We need to treat the disease process. And I think that's tremendous. What Prevention Point is doing is just fabulous. And I wish we could provide that to more areas of the country.
Yeah. I mean, it takes a whole nation of people here in this building to make it happen. But everybody's in tune with it. They're like, oh, I saw him this morning on the corner. Let me bring his medicine down to him.
Your infrastructure is quite impressive. Everything that you've described, from the nurses to phlebotomists, to even just the population knowing where to go, knowing where your building is, sleeping in front of your building. I mean, it's all tremendous.
Thank you. I mean, we it's a challenge, but it's a wonderful challenge, because sometimes I say to people when they're sitting across from me, and I say that they're crying, or they say I feel like shit, why am I still using it? And then they give me eye contact, and their eyes are sort of filled up, and I just look at them and I say, I see you in there. I see you, and I know you're trying really hard. And sometimes that is the connection. That's like every time that person now sees you on the street, they're like, hey, how are you? And that's respect. That's respectful, just being respectful of their humanity.
Now, Katie Pack did send in our chat. She just sent you a thank you for your insightful presentation.
Thank you everyone for listening. It was sort of a hodgepodge and a just sort of an overview of of what we do here. Other people do, like, I know there are lots of people across the nation that do the same thing, and in Canada and Australia, and we're all working for the same goal, to be able to eliminate hepatitis B and C.
So for the providers on here, if you have any interest, Susanna had provided a link in the chat below that you can sign up for one of our monthly trainings that we have for providers, and it is treating hepatitis C in a primary care setting. That's a virtual training. You do get continuing medical education credits for it, and it gives you some great insights provided by our nurse and physician program directors of our hepatitis C programs. Allison Cost is our nurse program director there, and she has a wonderful program that she provides. So keep that in mind, that every month we offer that the second Tuesday evening of every month online. And if you have any patients who are suffering from PBC and you're looking for a support group to give them some insight or support. We're starting a patient-led PBC support group. The first one is next Monday online, April 25th at 7 p.m. Eastern Standard Time. And the link is on our website. Susanna had also provided that in our chat. So please feel free to copy and share that with any of your patients, or if you yourself would like to participate to learn more about PBC. We also have our programs and events on our website. So if anybody has anything else to add, please unmute yourself and feel free to talk now. If not, we will see you next month in May for our talk with Julio Contreras about the law with HCV. And that is, again, the third Tuesday of May at 10 a.m.